We got a very full agenda today, so we want to make sure we start on time and we will finish on time, exactly 2 hours, if not less. If you notice the agenda, we have a lot of agenda items today, particularly there are 5 areas that we want to cover in great detail, best we can. But if you do the math, you see we have about 20 minutes per presentation today. So if you're presenting today, I ask you to be very, very brief and concise in your presentations. Committee members, if you would, make sure that your questions are very short and succinct. If you require follow-up, I would encourage you to get with the people who are testifying to provide additional explanation. With that, Becky, if you would, please call the roll.
Senator Rocky Adams, Senator Chambers Armstrong, Senator Berg, Senator Carroll,
Here.
Senator Douglas,
Present.
Senator Elkins,
Present.
Senator Funky Fromeyer, Senator Nemes,
Present.
Senator Tishner, Senator Wise, Representative Bentley, Representative Bratcher, Representative Bray, Representative Burke, Representative Callaway, Representative Camuel,
Here.
Representative Dotson, Representative Duvall,
Here.
Representative Fraser Gordon,
Yes, ma'am.
Representative Justice, Representative Neighbors,
Here.
Representative Rayburn, Representative Raymer,
Here.
Representative Riley, Representative Rourks, Representative Sharp,
Present.
Representative Wilner, Representative Winton, Co-Chair Mosier,
Here.
Chairman Meredith.
Present. We do have a quorum and duly conducted to conduct business. First item on the agenda is approval of minutes of our August 28th meeting. Motion and a second. All those in favor say aye. Aye. Any opposed? All right, thank you. Slight deviation from our agenda because we always run up to the last moment and want to look at our consideration of referred administrative regulations so that we make sure we get those out of the way because we have a tendency to lose our quorum towards the end of the meeting. Any questions or concerns about those regulations? Seeing none, I consider them approved. Moving on to our first agenda item. Senator Thomas, if you would, I'd ask you to come to the table. Senator Thomas wants to talk about Senate Bill 173, which was filed during the last session but did not get a hearing, so he asked me to allow him to testify today. Over the last couple of weeks, I've got a lot of interest in this bill, and I appreciate that. But I ask people to please bear in mind, very full agenda. We have about 20 minutes for this presentation. So if you would, please identify yourself for the record and proceed. Make sure your mic is on.
Thank you so much. First. Okay.
Oh, yeah.
If you would, please identify yourself for the record.
Yes, thank you, Senator Meredith. Thank you, Senator Meredith, Chair. I am State Senator Reginald Thomas, and I have with me today 3 individuals to present this bill. They're going to do most of the talking. I have with me Ms. Anjanette Pierce, who's seated in the middle, and they'll each announce themselves when they speak, followed by Ms. Susan Fruge. Fruge, thank you, French Canadian, and then Marie Allison. And we're going to talk about what was filed last year, Senate Bill 173. And what this bill does is that it allows parents of disabled children who live in independent residential homes to be able, Senator Meredith, to install cameras in their homes at no expense. There's no state costs. I want to emphasize that. But it is designed to protect those individuals who've been subject to abuse and harm while they've been living there, and to protect them. And I am all about protecting the rights of all people, and in this case, those who are disabled and cannot fend for themselves. So with that short statement, it's going to take about 12 minutes. There'll be time for questions. I will proceed by asking Ms. Anjanette Pierce to begin.
Thank you. Thank you. Thank you so much. My name is Anjanette Pierce. I'm going to start with a story about my daughter. Her name is Caroline. She has level 3 autism. For her, this means she watches Disney movies and pushes buttons on children's music books pretty much all day long. She cries a lot. She's nonverbal, can't communicate with a board or anything. And she doesn't laugh anymore. In 2009, we reached out for help with Caroline. The SCO waiver gave her a community home. Thank you so much for making this possible. For almost 8 years, she was safe in this setting with only 2 incidents, fingerprint bruises to her arms. But for the last 6 years, since receiving care from her current provider, she has continual, unexplained injuries. Doctors have found no medical reason for this sudden onset. Last fall, she had a bruise the size of an orange on the calf of her leg. It looked like someone hauled off and kicked her in anger. This bruise was buried in a multi-home investigation in which a whistleblower accused staff of locking Caroline in her room. Both crimes were dismissed because Caroline can't tell what happens. There are many more just as serious injuries. 107 out of 127 injury incident reports have no explanation. Even though she has the undivided attention of one staff person, it's called exceptional supports, 24 hours a day. She even has a baby monitor in her bedroom so she can always be heard. Staff works without on-site supervision. They can expose Caroline to strangers, and no one will know. Recently, she suffered 2 incidents of blue swollen fingers, a bruise the size of a $50 just above her left eyebrow, and a gash to the back of her head. These injuries are still under investigation, but nothing will be done because Caroline can't communicate at all. Each investigation takes about 45 days. They are a waste of time for her and a waste of taxpayer dollars. And no one in the unbelievable number of oversight agencies can help her. Here are just a few responses I received. Attorney General's Office. Because Caroline is nonverbal, she will have to be beaten near death before they can help her. Protection and Advocacy. P&A does not represent Caroline, nor are we able to do so. P&A provides client-directed advocacy, and unfortunately, Caroline is unable to provide such direction. The fact that someone has a legal guardian does not change this approach. The guardian has the authority to consent to the representation, but we must still look to the client for case direction. County Attorney. Incident reports show obvious cover-ups, but there's nothing he can do because the perpetrator can't be named. He says, get a camera. Urgent care and emergency room doctors say, get a camera. Police say, get a camera. Everyone who knows about this gives me this same advice because it's common sense. The problem is that SCO regulations don't allow guardians this choice and don't allow people to choose this for themselves because of privacy concerns. This is not just Caroline's story. Last year in Kentucky, according to DDID, 97 people were abused or neglected while in the care of private providers. That's a plane crash. That should be on the national news. And it gets worse. This data is only substantiated abuse? How many incidents were unsubstantiated because residents like Caroline are unable to communicate in any way? The National Council on Severe Autism writes, "We at NCSA hear repeated stories identical to what happens to Caroline. Injuries occur, investigations ensue, and nothing is substantiated because people with intellectual disabilities are incapable of telling their stories or coming to their own defense." And how many incidents went unreported because people are afraid to tell or were just not reported? Federal agencies say that despite the prevalence of abuse among people with disabilities, more than half of victims never seek help because they are afraid. And for every incident of group home abuse reported, nearly 24 additional cases remain unreported. And people living in group homes are at risk of serious harm. And 15 to 19,000 people with IDD are raped each year in the U.S., and most abuse occurs in group homes where 85% of cases go unreported. There are so many statistics like this. All you have to do is look on the DOJ website or ACL, I mean, you name it. This is not a plane crash. This is open season on people with disabilities. I'm not saying all community homes are bad. They can be a godsend. They were for Caroline in the beginning. But for some people, community homes are isolating and make people easy targets for predators. Oversight does not prevent abuse. We need a solution at the point of care. Our children need cameras. They need you to stand up for them. We're asking you to please sponsor this bill and do everything you can to pass it. This story needs to end so no one else has to feel Caroline's pain. Thank you, Susan.
Good morning. Whoa. Here, maybe here. Good morning. My name is Susan Rouget. We acknowledge that privacy concerns are important, but some people, like Caroline, do not understand this concept. Their disability is much like a child, and if they are not under constant observation, they are in danger of harm. There are many like Caroline who need guardians to make decisions for them. But this is not true for everyone. Some people are very aware of their privacy. This is why cameras must be a choice. This is why we also acknowledge that all people, even people with disabilities, must have a right to waive their privacy in favor of their own safety in their own homes. Denying them this right and denying guardians this right does not protect their privacy. It protects the privacy of abusers. Abusers who work with no on-site accountability. Abusers who carry cameras into community homes every day. Denying them this right, or to deny people with disabilities the right to waive their privacy, is a violation of their right to safety. It's way past time to give people with disabilities the means to protect themselves. But it's not too late for Kentucky to join the other 14 states who determined that cameras are not only a right, but a means to end this national tragedy. Kentucky needs to uphold federal HCBS guidelines, which require community homes to provide safeguards to ensure personal security and safety. We are asking you to include people with intellectual and developmental disabilities as citizens protected by the Kentucky Bill of Rights, which reads, all men by nature, free and equal, and have certain inherent and inalienable rights, among which may be reckoned the right of seeking and pursuing their safety and happiness. All we are asking is for you to defend this constitutional mandate and pass this bill. Thank you.
Hello, my name is Marie Allison, and I am the proud parent of a 49-year-old nonverbal individual who happens to be in the audience, who has a Supports for Community Living slot or services. A question arose as to whether the use of cameras in bedrooms would violate a federal regulation known as the Home and Community-Based Services Setting Final Rule. A final rule sets out new or revised requirements. On January 16th of 2014, the Centers for Medicare and Medicaid Services issued the final rule that establishes the requirements for the qualities of settings, such as community homes, that are eligible for Medicaid home and community-based services reimbursement. The fear was that the state would lose federal dollars if the proposed legislation was passed. However, there is no need to fear loss of federal funds. Utah passed a law allowing cameras to be used in community-based homes and explained how that does not violate the right to privacy under the federal rule. They noted that the final rule does not specifically discuss the allowance or prohibition of cameras. Removal of cameras is not a requirement of the settings rule. They stated that, quote, the use of cameras must be assessed against the Home and Community-Based Services Settings Rule to ensure that the presence and intended use of the cameras follows the rule. The federal government provided a residential self-assessment tool for the states to use to determine if a setting follows the final rule. It asks the question, quote, are cameras present in the setting? If yes, please provide evidence that the surveillance equipment has been authorized. Surveillance equipment may be used if it achieves one of the following. 1. Increased independence for individuals receiving home and community-based services. 2. Addresses a complex medical condition or other extreme circumstance. 3. Reduces or minimizes critical incidents. 4. Improves the quality of supports. The cameras must be the least restrictive option and have a method of secure disposal or destruction of any recordings after a reasonable period. The cameras must address health and safety concerns, potential risks and safety planning, and be visible. Concealed cameras are not allowed. We need this legislation to reduce the critical injury incidents that are occurring to people like Caroline, who are nonverbal and living in SCL residences. We need this legislation to address the safety needs of people like Caroline, who are nonverbal and cannot explain their bruises or injuries. We ask you to sponsor and pass Bill Request 42.
Thank you, Marie. I'm going to close with a few excerpts from some of our endorsers. A nurse practitioner who sees people with IDD under state guardianship I have bore witness to heinous and egregious acts of abuse, especially against individuals with disabilities. The ARC of Central Kentucky, while we recognize that the person has a right to privacy, we believe that the person has a right to waive that right to assure their safety. A retired provider, CEO, in the pursuit of human rights regarding privacy, we have at the same time violated the principle of person-centered planning for the very people we are seeking to protect. The chair of Together for Choice, who worked on camera regulations in Illinois, I am aware of no issues or adverse consequences arising from this legislation. And the president of the Autism Society of the Bluegrass, it is the right of us all to be protected in our homes. You or I can freely use technology, such as cameras, to enhance that protection. As the parent of a young man with autism, I would want no less for him. You would want the same for your loved ones. Members of this committee, this system is not preventing abuse. This bill will enable guardians to give their children the means to defend themselves. You can help stop group home abuse. All you have to do is pass this bill. Thank you so much.
Thank you. I appreciate your presentation. And Senator, we're out of time. If you want to give some closing comments, I do have the Cabinet of Protection and Advocacy wants to make a statement. So is there anything else that you need to say at this point?
No, I want, thank you, Mr. Chair, for your time. I want to inquire if any members of the committee had to answer or ask any
I
questions.
appreciate that, but we're not going to have time for questions. And what I'd encourage committee members to do is reach out to Senator Thomas. Again, this is a bill that I'm sure you will file for this next session.
Without a doubt.
We're not taking any action on this bill today. It's just a hearing to provide information. So everyone will have an opportunity between now and January and after we're in session to vet this thing in more detail. But I appreciate your testimony this morning and bring this before our committee.
Thank you, Mr. Chair.
With that, if representatives from the Kentucky Protection Advocacy will come forward, you have 5 minutes to present. Looks like a lot of folks coming to the table. Again, I'm not sure what the intent is here. We certainly want to hear you, but we're very limited time. Again, we have 5 minutes to conclude this portion of our agenda. So who will be speaking?
I'm going to just introduce myself. I'm Heidi Schisler. I'm the legal director at Protection and Advocacy. Just a little legal background. This is 1915C waivers. They are Medicaid waivers. That means they waive institutional levels of care. For the SCL program, that's at an ICF IID. The only ones in Kentucky that currently have a residential component are SCL that we've talked about, Supports for Community Living, and the 2 brain injury waivers. Those are usually provided in small settings, 3 to maybe 8 group homes, mostly 3-person settings. Talked about the settings rule. We've got some individuals who have probably more important things to say than I will.
They may, but I want to caution again, we're running out of time here, and I informed folks from Protection Advocacy that we only have 5 minutes to talk about this, so I need the delivery rather than the labor. Who's going to be speaking against this bill?
Corey?
If you would, please identify yourself for the record. I don't think your mic's on. Make sure the green light is lit.
Push that button. You got it.
There it is. My name is Corey Nett. Because of the time limit. My aide, Wendy Cooper, will read my testimony. While I respect what the senator's trying to do in Senate Bill 173, I think it is overreaching. I agree with the senator that we need to do everything possible to protect and weed out abuse and neglect cases from our waiver programs. But I must say I disagree with this bill 100%. Would he or anyone else propose a bill to put cameras in their own private areas of their homes, including bedrooms and bathrooms? This is not only an invasion of privacy on a far-reaching scale, but it also raises a lot of questions such as who's in charge of the videos, what safeguards are in place to protect the videos, if the participant in question is a minor, what about child pornography? Furthermore, who is looking out for the rights of the individuals? Even though I'm against this bill, I think that the senator came at it with good intentions, but no matter our intentions, we must always lead by protecting the basic rights of our participants. Everyone has the right to privacy and thus their civil rights.
One more.
Good morning. My name is Jordan Humphrey. I'm an adult who has a disability. I state that I am an adult because a lot of times we are not talked about like we are adults. This bill will take our rights away and treat us like we are not adults. Would you want a camera in your bedroom? I don't either. It's an invasion of privacy. And again, it does not treat me like I'm an adult. Just because I have a disability does not mean that I should not have the same rights as everyone else. A lot of times, the only place we do have time to ourselves is in our bedrooms. If a camera is there, that means that I don't have anywhere I can go to be alone. If someone is going to hurt me, I think that they will find somewhere else to do it. Don't take away our privacy. Please don't consider this bill.
Thank you. I appreciate your testimony, and obviously there's a lot of emotion assigned to this bill on both sides, and we certainly respect that. Again, I'm looking for Senator Thomas to file this bill next session. You folks very well know how the legislative process works. This filed last session did not get a hearing, so I can't tell you what the future of this bill is going to be going forward. But again, I'd encourage all of you to use the interim to get in touch with members of this committee, Senator Thomas, to talk about the concerns and what we need to do moving forward. But this is just kind of fact-finding today. But I appreciate everybody's testimony and being available to us today. Thank you for your time. Our next agenda item is House Bill 574. Co-Chair Moser filed this bill last session regarding provisional license to practice medicine. Good morning. If you would, please identify yourself for the record and proceed.
Yes. Thank you, Mr. Chair, and thank you, members. I am Representative Kim Mosier. I represent the 64th District, and I'll allow my guest to introduce himself.
Thank you, Representative. My name is Jonathan Wolfson. I'm the Chief Legal Officer and Policy Director at Cicero Action, which is a multi-state think tank that works across a bunch of states on this issue.
Thank you. So today, and I'll make this as fast as we can since we're running a little behind, but we have had many, many conversations about the physician shortage in Kentucky and nationwide. We have plenty of statistics to share with you. And I think everyone here knows that the physician supply is lagging patient demand nationally and across Kentucky. And as the supply falls, patients end up waiting longer to see a doctor, physicians experience burnout, and we lose even more and more doctors. We have nearly 40% of American physicians who are reaching retirement age by 2030. And by 2030, the U.S. will face a shortage of 120,000 physicians. 32.3% of Kentucky physicians are within retirement range right now. Kentucky is projected to be short nearly 3,000 doctors by 2030, and this especially affects primary care. We know that primary care is the most holistic practice in Kentucky and nationally, and we really need to find a way to improve our physician numbers here in Kentucky. We have a group, and I won't go through the rest of the statistics, maybe Jonathan will, but we have a potential solution to one piece of this. We have a well-trained group of physicians who have practiced or done their residency outside the United States, and we want to find a way to recognize their training and provide a provisional license. So I will just teeing this up and hand it over to Jonathan now for the details.
Thank you, Representative. And you all have these slide decks, so I'm not going to go through it step by step. We're happy to take meetings with anyone who would like to. But real quickly, just kind of talk through a couple things. The representative talked about the physician shortage. And I think that, in psychiatry, for example, Kentucky is the ratio of doctors to physicians or doctors to patients is 45% lower here in Kentucky than it is the national average. And it's already low nationally. We're not at the levels that are recommended. And so Kentucky has a shortage. And these shortages create problems. There's a bio of a doctor there who's a knee surgeon who does the knees of all the professional athletes in Europe. And right now, if the University of Kentucky wanted to bring him over and have him practice here, they would say he has to go back through his orthopedic residency in order to do it. No question he has this talent and ability, and there's doctors all over the world who look like this, and there's doctors who live in the United States. They may have been refugees who came over from Afghanistan, or they may have been individuals who are married to U.S. citizens who have been practicing overseas who would love to come back and live in a state, and this is an opportunity. And the only thing that they don't have, they have the right education that we expect of doctors in Kentucky. They can speak English. They've taken all the exact same exams. They have all the experience we would require, but they didn't do this residency in the United States. Now, if we had lots and lots of residency slots sitting unused, maybe then we would say, hey, let's just have them go do residency. The reality is about 7,000 people graduate from medical schools, apply for residencies in the United States every year, don't get them because we don't have enough slots. So that's a whole different challenge, but this is a way to circumvent that DC problem. DC created the problem. They capped the number of residency slots. That's a DC problem. We can solve it by allowing these doctors who've practiced overseas for at least 5 years and already have all the same training to practice here in the United States. And that's exactly what HB 574 would do. And so it really is, it's just that one change. It's just to allow a doctor who is sponsored by a healthcare facility here in the state of Kentucky, in the Commonwealth of Kentucky, they get a 3-year provisional license that allows them to practice as a full doctor, but they have to be working at that facility. They have to be supervised in some ways. They have to have that ability to check and see, hey, the way that they do billing in India might look a little different than the way that we do it here in the Commonwealth. And then ultimately, it's assuming that they don't have investigations pending, that they have been practicing the way that we would expect a doctor to practice, after 3 years, that license converts to a full license. And I think that it's important to recognize that the similar equivalent training requirement is definitely there. We want the medical board to be able to have the authority to say, no, this doctor went to a cut rate medical school, doesn't know what she or he is doing, can't pass the exams. Those doctors don't get licensed under this pathway. This still requires that they have residency abroad, but that they have the exams and all the other things that are done. This is a policy that has been enacted in a number of states around the country. There are 7 states right now that have a bill like this on the books. There were bills like this pending in a number of additional states, and we fully expect that in the upcoming legislative session across the country, we'll probably see another 8 to 10 states that do this. I will just say, I think that this is an opportunity for Kentucky to be still in the first 10 states that do this, because there is going to be competition. Ultimately, lots of states are going to be doing this. And if you want those top doctors from around the world, then the sooner that the Commonwealth of Kentucky gets on board, the easier it is for the hospitals in the state to retain those people. And lastly, I'll just mention that international training has long been recognized. In the United States, about a quarter of doctors do their medical training outside the United States and do residency here and become licensed. So this is not a question of, do we as a country recognize that you can in fact receive high quality medical training outside the United States. We do. We just have said, well, we're still going to make you do your residency here in order to practice, and that's just exacerbating the shortage. So with that, I'm happy to answer any questions. The representative is happy to answer any questions. We're also happy to take additional meetings if anyone would like. Thank you.
Excellent presentation. I appreciate that. And just an editorial note for the committee. If you notice, the balance of our agenda deals with healthcare workforce issues, and that certainly is intentional because it's still very pronounced, becoming more pronounced every day, especially in rural areas and urban, economic challenged areas. We're looking at solutions here, and I'm not suggesting this might be the solution, but it could be one step forward for us. So I appreciate that. Senator Berg, you have a question?
Thank you. Thank you very much for the presentation. I have in the past at the University of Louisville in the Department of Diagnostic Radiology, we have been able to bring over extremely well-trained physicians from Germany. And I have worked with them side by side for years. They are awesome, extraordinarily qualified. What is the difference?
Yeah, great question. So there are exceptions for universities if they are on faculty. So as long as they put someone on the faculty, but that limits their ability to practice, especially in rural areas, because obviously you don't have faculty opportunities. So and Senator, that's a great point. In the Commonwealth of Kentucky right now, there already are doctors who don't have residency in the United States that Louisville, that University of Kentucky, the university-connected facilities are able to retain as long as they're on faculty.
Thank you. And let me just add a line to that. The foreign trained physicians that I have had the opportunity to work with in my department have been exemplary. Thank you.
Thank you. Representative Frazier Gordon, you have a question?
Hi, thanks. I just wanted to know, is this something that KMA supports, or have you had discussions with them?
Yes, we are working together with all of our physician groups, and I haven't had a conversation with them in the last week, but I did last session, and they were having conversations internally to decide whether or not they supported this. So, yeah, we're all working together.
Senator Wise.
Thank you, Mr. Chairman. Representative Mosier, thank you for this piece of legislation over here. I'm sorry. We are this interim, you may or may not be aware of chairing a workforce attraction and retention task force. Representative Duval is the co-chair alongside me with that. Last meeting we had, there was a lot of issues such as this, of bureaucratic regulations we have in our state that are holding back healthcare professionals. I would encourage you to get with Representative Duval as we make our recommendations as a task force. This looks like something that really could be beneficial for us as we go forth with our recommendations to give to both House and Senate leadership, because I know the PAs are on the agenda next. I think this is all what we're seeing here is so many things that are holding us back. And as the chairman mentioned, especially for rural Kentucky areas, this is a must. I look forward to supporting this, but I just encourage you to get with my co-chair on this. Thank you.
Okay, thank you.
Thank you, Senator. Representative Bratcher.
Thank you, Chair. Just a quick question. Does this include DOs as well as MDs?
Yes, it would include DOs. Absolutely. I mean, I guess I should say, if you, the legislature, choose to not include them, obviously, you would have that authority to do that. But I think it's a good idea to include DOs. Yeah, and the bill does include them.
Before the meeting was called to order, Senator Douglas and I were having a sidebar conversation about this very subject. And one issue is supply, but the other is incentivizing people to practice in underserved areas. And historically, what we have seen, I don't think it's a lasting solution, because usually it's a hook for 3 or 4 years and then they leave. Is there anything within this bill, or could there be anything in this bill which would truly incentivize people to establish a long-term practice in an underserved area?
We can talk. We can look at that. We can, certainly try to provide some sort of incentive. I think that's a great idea. We have looked at that with our loan forgiveness program, and there are community needs assessments that determine what an underserved area really looks like in order to be granted a loan forgiveness package. So those are some things that we've worked on in the past, and yeah, certainly we can work on if you have ideas.
Well, just a war story. When I was a hospital CEO, I recruited an otolaryngologist from Nova Scotia. And he just liked the quality of life, but he also liked the fact that when he was in Nova Scotia, which has a population of about 1 million people, he was only one of 3 otolaryngologists, whereas in Jefferson County, I think there's an excess of almost 70 ENT. So it goes back to that maldistribution of physicians, and that is creating havoc for us. And again, we don't really measure the cost of doing nothing, and it is quite substantial, but I think this is an interesting prospect. Anyone else have any questions, comments? If not, thank you for your presentation.
Thank you.
Next on the agenda is a discussion about physician assistants and collaborative agreements. And I think I see on my agenda we have 4 people that have will be testifying. Don't know where y'all want to come up together. Feel free to. First on my agenda is Brandon Embry. Mr. Embry, we've had numerous telephone conversations, and I appreciate the opportunity to meet you in person, and appreciate you being here this morning. If you would, make sure your green light is on the microphone.
Yes.
And identify yourself for the record. Feel free to proceed.
Sure. Thank you, Senator Meredith. This is my friend and colleague, Jason DeLong. We've been friends for years, and he's here with me today in support of this and this conversation that we're going to have. And as you said, my name is Brandon Embry, and I appreciate y'all having us and listening to us today. After speaking with my father, he ran into Senator Meredith, and they had a conversation, and he was gracious to let me reach out to him, talk with him, and then have me here today to speak with you all. So I appreciate that, Senator Meredith. I do want to note that I am not receiving any compensation for being here. I am not on the board of a local organization or a national organization. I'm merely taking a vacation day to come on behalf of my profession and to advocate for us. So, a little background on myself. I'm from Hartford, Kentucky. I was born and raised there, graduated from Ohio County High School in 1994, went to Murray State University, graduated in 1998, then transitioned to PA school at the University of Kentucky and graduated in 2000. So I am born Kentuckian, raised, trained, and now practice my profession in this state. And I love Kentucky. I love the Kentuckians that I get to treat on a daily basis, and I love my profession. Looking back over my career, I've seen a lot of change. 24 years into this, and I remember the days of having to use a Merck manual to look up information and carry a pharmacopoeia, and now we have smartphones in our hands and access to information instantly. We have transitioned from paper charting to EMR, and now AI is on the horizon. You know, medicine is changing. It's always changing, and life is changing, and that's part of it. I do want to piggyback on the healthcare crisis that was just discussed. I do see this as a dilemma in medicine and healthcare in the state of Kentucky, and it's also a crisis nationally, but I want to focus on Kentucky. Over the past several years, there's been a trend where access is becoming an issue, and we're seeing shortages all across the state. The data that was just shared, I think it's worth repeating that the U.S. is to have 120,000 too few doctors nationally, and Kentucky is projected to have 3,000 too few physicians by 2030. 107 of our 120 counties are healthcare professional shortage areas. There's 3,500 or more patients for every one provider. Kentucky ranks 40th for primary care doctor availability and overall physician supply. Physician to patient ratio is 86% worse for infectious disease, 47% worse for internal medicine, 36% worse for pediatric critical care, 40% worse in preventative medicine, and 45% worse in psychiatry for Kentucky than the national average. I believe the reason for this can be multifactorial. College expenses have increased to the point where physicians graduate with tremendous amount of debt. Makes it challenging for them to practice in primary care. I think insurance companies make it difficult for us to do what we need to do. I think there is barriers when it comes to ordering tests, medications, surgeries that patients need, procedures. It's a tough environment. Long gone are the days when I could order an MRI because I thought someone had a meniscal tear based on history, physical exam, and my interpretation. Everything is pre-certed. Physicians and providers are getting burned out. There's less physicians going into primary care. Physicians are taking retirement, as stated earlier in the previous presentation, but they're taking retirement earlier because of headaches and stress. In Kentucky, 32% of physicians are within retirement age. Many are fed up, stressed, and tired. Currently, healthcare workers are among the highest of any profession to experience burnout. So I'm here today to ask you to free us up so that we can help. PAs have been around a long time. The profession was established in 1967. Prior to that, we functioned in a similar role in the military. There are approximately 178,700 in the U.S. practicing currently and 1,850 in Kentucky. There are 308 programs and 4 in our state. We have a bachelor's degree, have to have a bachelor's degree to enter the program, and the length of training is approximately 27 months. We have 2,000 hours of in-person clinical experience prior to graduation in several different fields of medicine. We have to have 100 hours of CME every 2 years, and we have to recertify every 10. This used to be every 6. We are well trained, and we are trained on the same didactic training model that mirrors that of physicians. We're taught to think critically about how to treat disease states. Do you know that half the PAs trained in the state, however, leave? There are PAs practicing in Owensboro, Louisville, Northern Kentucky that cross the river. Why is that? Because those states are more PA friendly with their laws and regulations. I wanted to discuss 3 issues today that I think are pertinent and that would help move us in the right direction. I think the first one has been discussed in the past, but I want to discuss it again, and that is to let us prescribe Schedule II medications. We are one of 2 states who do not allow PAs to prescribe Schedule II medications to some degree. The second is to simplify the supervising physician process. I brought with me today a sample of our application process for the state of Kentucky. And it's 15 pages, okay? We recently hired a PA at the end of July, and it took her a month to get a temporary approval for a supervising physician, so she functioned as a PA student for a month, and she has 10 years experience. This is the state of Illinois. It's 1 page. My third ask would be let us bill insurances directly and receive payments. 11 states across the nation allow PAs to do this. There are other states that do not have language in their laws for or against, which allows PAs to do this. But Kentucky explicitly says that we cannot bill or receive direct payment from insurance companies, even though it's allowed federally. So in conclusion, I'm asking to make some of these changes that would help free us up so that we can help with the crisis that we're seeing for patient access. Mobilize us, use us to the full extent of our training and our skills. We want to help, but there's some laws in place that hold us back and would help, you can help us implement this change. So help us move up the ladder in quality as far as the healthcare that's given in the state of Kentucky, because we don't have to be 40th. I'm going to give you some numbers from the recent Harris poll that showed support of PAs. 94% of Kentuckians believe PAs should be allowed to provide care to the fullest extent of their education, training, and experience. 90% in Kentucky of Kentuckians believe PAs should be utilized to address healthcare workforce shortages. 94% in Kentucky believe fully utilizing all trained and educated healthcare providers, including PAs, improves patient health. 92% in Kentucky believe PA practice laws should be updated to allow states and healthcare systems to fully utilize their healthcare workforce. 85% nationally and 84% in Kentucky believe patient access to care should not be restricted by laws that place limits on the care a PA has been educated and trained to provide. 70% of people in Kentucky say that they would trust a PA to serve as their primary care provider. 75% of Kentuckians who have seen a PA rate the medical care they received from a PA in the past 12 months as either good or excellent. 93% of people believe PAs add value to healthcare teams. 89% believe PAs improve healthcare outcomes for patients. On average in Kentucky, it takes a month or more to get a needed appointment with a healthcare provider. Nearly half of Kentuckians, 48%, say they delayed or skipped care. 61% of Kentuckians are less likely to seek care unless they are sick. Moreover, 6 in 10 adults in Kentucky who delayed or skipped care within the past 2 years experienced some kind of impact as a result: worsening condition, negative impact on mental health, or loss of faith in the healthcare system. So I'm asking you, please consider allowing us to use our training and our skill set to provide care and have allow better access so that patients can be treated in this state. Thank you.
Thank you. Appreciate your testimony. Very, very good. We also have 3 people from your academy that wants to testify on behalf of this. So I'd ask you to kind of step away, but be prepared to entertain questions, because we do have some questions for you. But
yes,
just in case I don't want to duplicate efforts, and so.
Absolutely. Thank you.
Thank you. Good morning. Appreciate you being here. I know you know the routine, but if you would, please make sure your mic is lit and pulled close to you, and identify yourself for the record, and feel free to proceed.
All right. Thank you, Chairman Meredith, Chairwoman Mosier, and committee members for allowing me to be here today. I'm Andrew Rutherford. I'm a critical care PA in Lexington. I am also chair of the Kentucky Academy of PAs Government Affairs Committee, and I'll ask my colleagues to introduce themselves.
My name is Erin Chalmers. I am the president of the Kentucky Academy of Physician Assistants. I'm also the associate program director at the Sullivan University PA program, and I practice pediatrics in Shelbyville, Kentucky.
My name is Ashton Ogle. I am a PA working in a local emergency department.
All right, and we will be brief. Brandon came to us after being asked to testify, and we spoke with Senator Meredith, and he graciously kind of asked us to talk about collaborative practice versus that of supervision, and kind of why collaboration may be more important and better language for our legislation compared to supervision. So the first thing we'd really like to talk about is kind of words matter. As people, if you don't know medicine, words do matter. So when I say, my supervising physician is Dr. Jesselkamp, that's one of my supervising physicians. People say, oh, so you're in training still. That's really hard to build rapport, especially in an ICU where I am collaborating with my physician. We have set a plan forward, but she knows that I am trained to operate in certain ways and do certain procedures, and so I will move forward with those. It really lends to more of an academic type setting of I'm a trainee, we're still in training, we're not actually practicing providers. Where collaboration, I think it's one of those, and I think everyone here has always heard us as CAPA, we want to be part of a physician-led healthcare team. But we want to be part of a team, a collaborative type team. That's really how medicine's working now, is interdisciplinary teams that really shows collaboration. We really want to let people understand that we are licensed healthcare providers, and we feel that collaboration is a better way of letting people know that. And then actually switching to collaboration is one of those things that a study that was published here in the Journal of Medical Regulation showed that moving from supervising language to collaborative language reduces physician malpractice significantly. It reduces malpractice claims on physicians significantly, while PA claims, they don't go up, they don't go down, they kind of stay exactly the same. What it does is it allows PAs to take ownership of the medicine that we practice while decreasing the liability on physicians. So as we talk about physician burnout, one of those things is a lot of the things that, supervisory rules, a lot of our language. So this is a way to help decrease those malpractice claims and decrease liability for physicians. In here, there are some other things that were within that paper. You all have the PowerPoint, and we'll let you all review those. And then kind of the conclusion. The second thing, as Brandon kind of alluded to, is there is an extreme amount of administrative burden when a clinical site, a hospital, an institution decides to hire a PA. He showed you kind of what our supervising physician agreement is. It's 15 pages long, and it's not that it's just the length, it's very complex. Credentialing people who have done this forever with PAs are still very confused. Anytime we update legislation to try to make it easier to hire a PA, it actually makes things harder. And a lot of it comes because the language is very it needs updated, and that's what we want to do. We want to work with you all. We want to work with all of our stakeholders to really update our language to mirror how medicine is working in Kentucky and provide better care. So this transition to collaborative language will also allow PAs to be more competitive in the job market. We don't really, I think there's always a misnomer that we compete with physicians for jobs. Honestly, I don't believe that's true. My wife's a physician, and I've talked to her about it, and she says she never sees a position that's physician, NP, or PA. It's either a physician job or it's an APP job. Currently, we can't compete with our nurse practitioner colleagues. It's much easier to hire them. It's much easier for them to practice. And so therefore, it's one of those that moving towards a collaborative practice would allow us to be more competitive in a job market, which may allow us to retain students. Here, this is just for reference. This is kind of how Kentucky looks. Our national organization, AAPA, has 6 key elements. Kentucky, as you see, we have 2 out of the 6, and we always tailor our legislation to what Kentucky needs. But it does show, we're kind of behind, and we're deemed restrictive. Throughout the nation, we're deemed, if you look us up, we're a restrictive state for PA practice, and we would like to update that. This is just once again showing all the counties that are healthcare professional shortage areas in Kentucky. And so I think it's not a one-pronged approach to really provide care to Kentuckians, and PAs just want to be a part of that. I'm not going to sit here and reiterate, I know Brandon gave you all this, but I do think one of the things he said that's really important to take a hold of is that 94% of Kentuckians believe PAs should be allowed to provide care to the fullest extent of their education and training. And so I think that shows that Kentuckians, they want health care, and they want people to be able to practice health care. So once again, we're very much a fully transparent organization. We're not going to sit here and say, we're this or that. But I do think in equity type access that we need to really move towards where we can be more competitive in a job market compared to some of our colleagues and allow us to practice fully. And we think moving towards collaboration would allow that. With that being the case, there's references for anything that we've mentioned here if anyone's more interested. And we'll open up the floor for any questions.
All right, thank you. And Mr. Interim, if you could come up to the table with this group as well. I think the first question is from you, from Senator Funky Frohmeyer. Senator Frohmeyer.
And I believe any of you could address a question, but you did bring up the 15-page application. So I'm a layman on that. If I were to understand what is the scope and nature trying to be accomplished with the 15-page versus what's the scope that's trying to be accomplished with the 1-page, what's the difference, and where is that sort of bureaucratic friction? How can we help reduce that bureaucratic friction, if you could be specific?
Personally, speaking to it just from my angle, from someone that's been in the field, I've worked 9 years in family practice and then transitioned to orthopedic surgery, 2 totally different practices. However, I've worked with great physicians, and within the practice, the relationship is established between me and my physician with what he is comfortable with allowing me to do. And so there, you go from family practice to orthopedic surgery, there's a learning curve, right? But as you learn and as you gain experience, the surgeon gains confidence in your abilities, and therefore the surgeon is the one who is controlling his practice and how he utilizes his PA instead of the government doing that. Instead of putting a 15-page document that has so much information, there's almost no way to police that. It puts it back on the physicians and their relationship with the PAs. Does that make sense? So,
well, and that's where I wonder the 15 pages versus the 1-page. Is the 1-page then ultimately establishing who is the physician-led collaboration versus the 15 pages trying to justify a need or something? I'm trying to recognize why 15 pages versus 1.
So Illinois is a state that uses collaboration as a term. And so it's very similar in the sense that they're just saying, okay, who's your collaborating physician and how are you going to be utilized? Versus our current process, because our language has a very long document of basically things that a supervising physician must do. So a lot of our document is an affidavit that physicians are having to sign that says, I will make sure my PA doesn't do anything wrong. It includes papers that we have to go get notarized. It includes, and that's for me and also the physician. So there's two different notary type things. So it's very much a reinforcement of what our language is, but a lot of it is that in collaborative type situations, it's normally at the practice level where scope of practice and everything is deemed, and then versus it being at the state level and the regulatory board.
And in the state of Kentucky, you have to fill that out by hand and mail it with a stamp. Like there's no online process, and there's no faxing, no emailing. So
I was recently licensed in both Indiana and Pennsylvania, and it was a simple online application. I know Ashton is born and raised in Kentucky, chose to stay in Connecticut where she did her training because the laws were less restrictive.
Thank you. Committee members, we have 7 committee members who have asked to ask questions. We have between 10 and 15 minutes for this section, so please be brief in your question. And folks, if you can give a one-word answer, I'd appreciate that as well. But Senator Titchener.
Thank you. Okay, so if we loosen these restrictions, do we have a pathway in our universities for people to go through the program? I know we have restrictions around the number of residency spots that are available in our schools of medicine. What about the PA programs in our universities? Do we need to make any adjustments there?
No, we don't. So I work in PA education. Residencies are optional for PAs. We do have more and more PAs who are seeking out additional training, but it's not required. And there would need to be no adjustments to their education or training to change this language to collaborative.
I would add that I feel like the term collaboration actually depicts what we already do. It's not changing our scope of practice. It's not changing. I do not have a supervising physician that stands over my shoulder and tells me what to do. I work in a medical team. My supervising physicians work with other specialists as well, and it really just modernizes the language to what we're already doing in practice.
Representative Wilner.
Thank you, Mr. Chairman. Thank you. I think all of us on this committee are painfully aware of the provider shortage. Many of us have experienced personally how difficult it can be to find a provider. You've offered a great part of a solution to the problem, provided some evidence for how this is working well in other states. And I'm just curious, what is the barrier? What's preventing this from getting through? Is it just turf issues or what is it?
So a lot of it sometimes I do think it's probably a lack of education. There is some turf, but I think sometimes it's a lack of education of how things are working. And honestly, you know, I'm not, this isn't anyone else or anything. I think as a healthcare community, we need to be better as stakeholders to all sit down to figure out what's best for Kentucky. I think sometimes it's very difficult to get people on the same page, and that unfortunately exacerbates kind of what's seen as a turf issue versus, hey, we want to work to make things better for Kentucky. So.
Thank
Senator
you.
Carroll.
Thank you, Mr. Chairman, and thank you all for being here today. We talk a lot about expanding practice for PAs, nurse practitioners. Are there opportunities for PAs, maybe those that have been in practice for several years, to streamline the process to become an MD? I mean, I know there's differences with the residency and other requirements, but are there opportunities to make that pathway easier for you all to become MDs?
There are currently no bridge programs to allow PAs or NPs that I know of to become MDs. From best of my understanding, it would be starting completely over, going to medical school, going through residency. So it would be another 8 to 12 years, depending on the specialty that you chose.
So are there ever any discussions about that with the shortage we have
Can
in
I just
MDs?
add to that? I don't think that's what any PA or nurse practitioner is set out to do, is to become become an MD. We're not in training. This is our profession. We diagnose patients, we treat patients, we prescribe. We do everything based on our training, and we're trained to be PAs, or we're trained to be APRNs. And we're not trying to go to medical school or trying to do that. We already see there's a huge issue with even finding residencies. So the PA profession itself is geared to and designed to fill in the barriers and fill in the access to healthcare gaps, working on a team to increase the amount of patients that we can reach, not that we can later go to medical school and become a
And I'm not
physician.
saying that every one of you
Yeah.
would want to, but there may be some
Sure.
that, after 10 years or so, they're ready to make that next step. And do we need, and I know you can't just do it on the state level, there's more to consider in working towards a process to make that easier.
Anecdotally, my cousin is a nurse practitioner, and she is in year 2 of medical school now, so she has started all the way over.
Okay, thank you. And for those that don't know, Murray State and the University of Louisville has entered into an agreement. Murray State will be starting a medical school on campus. It'll be a 2+2 with University of Louisville, in hopes that eventually it will become a full medical school. And Baptist Health Paducah will be providing residencies for that. And there is hope that Mercy Health in Paducah will also be doing that. So that's something that our universities are working towards to help in the Commonwealth. Thank you, Mr. Chairman.
Senator Douglas.
Thank you, Mr. Chairman. Not really a question, but just a few comments. We talk a lot about the maldistribution in the healthcare system. That is one of the biggest reasons why we have shortages. The numbers are down, but let's not forget maldistribution. And pushing more people through the funnel won't improve anything unless you improve the distribution of healthcare workers across the Commonwealth. Don't forget that. 2 other things. I don't know about you guys, but when I do my privilege forms, I have no idea how many pages I have to fill out every year. And I talk to the people in administration and say, I knew you before you started having kids. I fill out these forms every year. And I've been doing this for 30, 40 years. You know who I am. I still have to fill them out. It's part of doing business, folks. The third thing, you gave a lot of really good statistics about the public in terms of wanting PAs to do certain things. But I wonder how many of those people that were interviewed truly know the difference between the training requirements of a PA and a nurse practitioner and a physician. I would guess that would be very, 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 very high 90s. So I'm not sure how valid those studies are in the real picture. Look, I also want to solve some of the healthcare crisis that we have here in the Commonwealth. I've been part of it all of these years, just as Dr. Berg has. We get it. People think we don't, but I think we have to be very careful and very thoughtful about how we do this. Thank you, Mr. Chairman.
Thank you, Senator Nemes.
Yes, thank you, Mr. Chair. And I too, just more of comments and questions that I don't want answered. I want you to come to my office and answer them. We all know there's a need for health care. And this keeps coming up. You keep coming back. And I once again, like Dr. Douglas, these polls, they don't address this. Everybody's going to say yes to, do you want you to utilize your training? What is your training? They don't ask that in the poll. But do they really know the difference between a PA and a doctor? They don't say, in the poll, you don't say, do you want the PA to do what a doctor is trained for? And if you're trained so extensively and so long, why don't you go to med school? You just want to charge as a doctor? I know you do the basic work, just like my granddaughter. When you come into the optometrist and ophthalmologist, she does the basic stuff of check your eyes and this and that, but she's not an ophthalmologist. And you also talked about you compete with doctors for jobs. That's not true. It sounds like you're wanting to do what doctors are trained for. If we let others do what doctors do, then why go to med school? So I'd like those answers before we go on to give you more authority. Yes, we need more health care. Thank you.
I would just like to make sure everyone's aware. We during our presentation, we discussed that we mainly compete for jobs with APRNs, and we don't do that with physicians. That if job postings, they're for physicians, they're not APRN. They're not for physician or PA or APRN. They're for APPs, which is kind of a lump for APRNs and PAs, and then physicians are separate from that. So we aren't trying to compete on that level. And it's one thing that I do want to make sure is very clear. We're looking to collaborate with physicians. We're not looking to cut a cord, nothing like that. We just know our training. We know how other states have utilized PAs, and it's allowed their healthcare to improve, and we just want to be utilized to that aspect of it.
Just another editorial note, there's not been a bill developed for this yet. That's something we'll be talking about in the next few months, but I appreciate your concerns, Senator Nemes. Senator Berg, and we'll finish with Representative Co-Chair Mosier.
Thank you, Mr. Chairman, and thank you guys for your presentation. I personally would agree that collaboration is a better word than supervision. We try to collaborate in medicine. But I do have a question on the last page of the data that you presented, medical profession comparison chart. Unfortunately for the MDs, you put 2 years in the classroom, whereas everybody else you go by hours. So I was trying to make, apples to apples. Can I safely assume, given a 50-week year, because we give our medical students 2 weeks off, 50 times 50 would be 100, minimum of 40 hours a week. As a medical student, actually, you're really working more like 60 to 80 hours a week. So we're talking about 4,000 hours in the classroom for an MD versus 1,000, 4 times the didactic training, twice the clinical requirements, and then we, of course, are required to do residencies for a minimum of 3 years, typically. So, when you're talking about the comparison between the years and the degree of education, there is honestly no reasonable comparison. I, myself, 4 years of undergraduate, 4 years of medical school, 5 years of postgraduate training before I was able to put myself out as a licensed practicing radiologist. And that is something that as we go forward, guys, we have to remember, not just for my profession, for your profession, which I totally agree needs to be collaborative, but we also have to be honest to the people we're serving in this state. And the truth is, most of them don't understand the difference between a PA and an MD. So as we go forward, and I am certainly in support of some of the things you're asking for, I think we need to make sure that we don't do a disservice to our public. Thank you.
Thank you, Senator. The last question, comment from Co-Chair Moser.
Thank you, Mr. Chairman, and I have a couple, but I'll make it fast. I feel like we update PA regulations almost every year. We have something that we work on. So, I'm all for modernizing and certainly simplifying the application process seems easy. I mean, that doesn't seem tricky to go online, maybe even for physicians as well. I have a question about the Schedule II prescriptions. Are you looking to, under a collaborative agreement, are you looking to move toward some sort of CAPA CS like we did with APRNs? What is the collaboration that you're looking for as far as prescriptions, or do you just want independent practice when it comes to prescribing?
No independent practice at all. So it was a bill that we actually brought forth when we passed prescriptive authority through your committee, where it was just controlled twos, and I don't have the language in front of me, I'm sorry, but for like kind of the opioid stuff, it was 3 days. It mirrored that of NPs, but it would be under the discretion of our current supervising physician, if we did collaborative physician, whether or not they wanted us to kind of have that. But it wouldn't be a Kappa CS. It would be deemed underneath just with our collaborative agreement.
Okay,
So
so you're not looking for like a length of time to collaborate or
No,
practice under a physician?
No,
and
ma'am.
then-
This is
okay.
this is more updating the language to reflect that we truly more collaborate with our physicians, and that it also, I'm going to speak personally here. My wife's a physician. She's a hospitalist. I talk to her. She says supervisory language scares her. It makes her nervous to work with PAs because of that, even though she may rather work with PAs versus collaborative language, which to her feels more real. And so,
Right.
but we're not looking to ever move towards independent practice of any.
Okay. Yeah, I would agree that the language supervision versus collaboration is, that seems to make sense to me. I like more collaborative practice. And then on the question about billing directly in alignment with the federal laws, are you looking for pay parity or just to be able to bill independently?
I think being able to bill independently is essentially the motivation behind that. And remember that if a physician bills if a PA bills without a physician on site, and I think I understand this correctly, then we get 85% of that reimbursement. It's not 100%. So as a PA, there's still things that come into play there that show that we're not trying to be independent. We're not trying to compete with physicians. On the federal level, Medicare reimburses us at 85%. That's the incident to policy. So, I think it's just allowing to bill and collect. Through insurance companies, it's allowed on the federal level, and it's just, I guess, as simple as that.
Right. Okay.
Yeah.
All right. Well, thank you for that answer. That does help clarify. And I just want to be sure that you're not looking to change the name physician assistant to anything different. Is that correct?
That's nothing we have discussed at this time.
At this time.
Things will change. It's not something that's even on our agenda looking ahead in any near future. Like, I can't sit here as someone that I may not be in this role after another couple of years. We're a volunteer board. So I'm not sure. But no, that's nothing that we're looking for. We're not looking for independence. We're just looking to be able to be better utilized.
Okay. All right. Because I have heard that the national board, and this is completely anecdotal. I don't have any true data about this or information, but that PAs were looking to move from the title physician assistant to physician associate. So is that on the radar?
That's nationally our American Academy. It's the American Academy of Physician Associates. Similar to changing things to collaborative practice, they felt associate better represented how we work on the medical team, as we're not an assistant. But that is a national thing. We are the Kentucky Academy of Physician Assistants. Our legislation, everything is physician assistant, and it is that way nationally in all the other states as well, in terms of legislation and what we do.
Okay.
Most of us call ourselves PAs.
Well, right. Yeah, exactly. And I'm not sure that everyone knows what that stands for, but I just feel like as we change language, we're moving toward, a little more independent practice. And I just want to make sure that, we value your work and the training of physicians and APRNs and PAs independently. That doesn't mean independent practice.
Could I reiterate that we are not seeking independent practice? That is not a goal. We are also not claiming to be physicians. I have never claimed to be a physician. I am a proud PA. I'm a proud member of the healthcare team.
Right.
And more than anything, I'm a proud Kentuckian, and I would like to stay here and help my state.
I appreciate that very much.
Thank
you.
I appreciate your testimony this morning. You provided us with wealth of information, and I'm sure we'll have further discussions going forward. But thank you for being here. Our next presentation is an update on federal minimum standards for the long-term care facilities. Certainly, the reason for this agenda item is these new federal standards are going to impact workforce requirements that will reverberate throughout the healthcare industry. So I've asked our friends at the Association of Healthcare Facilities and Assisted Living to kind of give us an update as to what they think the impact is going to be upon their respective facilities. So appreciate you being here. If you would, identify yourself for the record. Make sure your green light is on your mic, and feel free to proceed after that.
Thank you so much. I am Lisa Biddlepuffer. I am the Vice President of Quality and Regulatory Affairs for the Kentucky Association of Healthcare Facilities. And Jeremy, will you introduce yourself?
Yes, my name is Jeremy Bischoff, and I'm the Vice President of Reimbursement for the Kentucky Association of Healthcare Facilities. I will also add that both Lisa and myself are licensed nursing home administrators in the state of Kentucky.
And I will say that as licensed nursing home administrators, we have also been extremely proud to work along the front lines of the folks who were heroically helping our vulnerable Kentuckians during the pandemic. And that's something I know we're both really proud of, but I also want to say that what we're facing with this minimum staffing standard is one of the things that our coworkers have talked about as being one of the biggest threats that we're facing after the pandemic. So today we are going to talk about the impact of the federal staffing mandates on Kentucky's long-term care facilities. And just briefly, 2.5 years ago, CMS did propose to create nursing home staffing requirements, and the public provided more than 46,000 comments. CMS commissioned a study, and that study actually shared that no single staffing level would be guaranteeing quality of care. And those of us who have worked in this profession know that basing staffing decisions really needs to come from the individual residents and patients who are getting care and what their specific care needs are. Despite this study, CMS did finalize the requirements on April 22nd of 24. And the requirements are, as you can see, a minimum of 3.4 hours of nursing care per resident per day. 0.55 of that 3.48 needs to be based on registered nurse time. In addition to that, and this is perhaps the biggest challenge given our workforce crisis, is there's a requirement for a nurse, a registered nurse that is, to be on site at all times. CMS does have deadlines for compliance that are phased based on whether facilities are in an urban setting or rural setting. An urban setting would be 2 to 3 years, rural 3 to 5. But the timing of this is dreadful, to be honest. This graph shows along the side, this is the percent of change from February 2020 for the workforce in all of these healthcare sectors. And you can see from the graph that despite nursing homes increasing wages 27% on average, which is more than other healthcare sectors, nursing homes are still losing the most ground on having a workforce in place. We'd love to hire more workers, and we focused on lots of things during this time, not just raising their wages, but we've also been focusing on more creative ways of looking at getting workforce in our facilities, including considering second chance hiring and other ideas that are new for Kentucky. We certainly have also been trying to find more foreign-born workers, so that goes in line with what we just talked about. I will say that from that graph that you just saw, you can see that while hospitals and other clinics have recovered, we're still struggling in nursing facilities because we're facing this crisis. And it's mostly to recruit RNs, registered nurses, but also nurse aides. I will say the other challenge that we're facing is that we all know that our population of elders is growing rapidly, and our concern is that we're not going to have enough younger people to provide the care that we need for them. It really makes no sense right now to have staffing mandates at a time when we're having the most changing demographics for the elders that we serve and the highest caregiver shortage. CMS is allowing for some exemptions or waivers, but they require extensive eligibility requirements, and any exclusion is going to be a very big challenge for our providers who are nursing home operators. And some of those would include having to show that there's a local workforce that is 20% below the national average. Facilities would have to show good faith efforts to hire and have to demonstrate their financial commitment to make sure they're hiring. The other issue is that facilities can't request an exemption. That's something that happens when an inspection occurs. So once they're out of compliance, when inspectors walk in, that's when an exemption could be granted. And then that exemption would not last, would stop at the end of the survey cycle. So when the next survey team walks in, there would have to be another allegation and proof that the facility had done everything they could to be exempt. The other challenge is that facilities have to post this publicly if they have an exemption, so that's going to be significantly tough for folks to want to come. Enforcement is also a big hit for nursing homes, and the penalties and fines are one thing, but the potential for Medicare and Medicaid to stop and terminate their agreements is essentially the same as closure. Basically what this is doing is this is a mandate that's lacking an understanding of what's going on in the real world of healthcare. And the unintended consequences of this will be to impact the residents who are living in long-term care. The care won't, the costs that will be given away to fines and penalties are going to be put toward having to pay for more agency staff, which is a temporary type of staff that does not align with the best interest of the residents. Sometimes it's all we've got, but that's not helpful to the residents. And rather than decreasing staff burnout, it's actually going to accelerate it. Because when we can't find additional caregivers because they don't exist, the people who are providing care in the nursing homes are going to be working longer hours. They're going to pick up extra shifts, and we're going to be driving away those talented, compassionate caregivers who have been staying, and that's just not what we want. And ultimately, closure is the ultimate penalty for the vulnerable Kentuckians that are being served in nursing homes. Just an update on where things stand with the federal Congress. There has been bipartisan support to overturn the administration's staffing mandate, but at this time, they will not be pursuing that because the president would veto it. The American Healthcare Association, for which we are a state affiliate, has filed a lawsuit in Texas against this mandate, basically because the people are not there and there are no funds. In Kentucky, we're especially vulnerable, and we're vulnerable in both rural and urban areas. In rural areas, and we talk about this a lot, is rural areas don't have the nurses or the nurse aides, so the staff access is really tough. But I also want to argue that having worked in an urban area, those facilities are facing significant competition from providers that have significantly more funds and can offer quite a bit more flexibility. So a nurse can frankly work from home and make a lot more money. It's very difficult in an urban setting to find a registered nurse who could go anywhere she or he would like to get a job, and now to ask them to come and work at nights and weekends. 82% of Kentucky's nursing homes don't meet these new requirements. Only 6% meet all four, which would be 16 out of the 265 that we have in our state. The cost, 70 $9.5 million for Kentucky, and there's no clear funding source for this. Here's a graph from the Kentucky Board of Nursing that shows where registered nurses are across the state. And while it may not be the easiest to read, I think you can see the story with the colors, which show how hard it is to find registered nurses in some areas. We support having registered nurses more readily available in our nation's nursing homes, and especially in Kentucky. But the challenge is, as we've been hearing you all talk about today and in other of your committee meetings, the crisis that the healthcare system is facing with staffing is making this a near impossible. Only 3% of registered nurses in Kentucky are working in nursing homes. Most work in hospitals. Now hospitals are using licensed practical nurses because of their own staffing shortages, and licensed practical nurses have been the backbone of care and long-term care for all this time. The other issue, and you all know this well, but 28% of licensed practical nurses and 5% of registered nurses who work in long-term care nursing homes are age 55 and above, so they're going to be retiring soon. This problem will be getting worse.
Thank you, Lisa, and thank you all. So when we look at the unfunded mandate and the unrealistic expectations, the reality is that this mandate came out with no funding put toward it from a financial end to support the workforce expenditures that are going to have to be put in place, to support the recruiting efforts that are going to have to be put into place. And the funding that was put toward this was $75 million from CMS, which was put into place to be able to help to develop additional RNs and to develop additional staffing and workforce. To give you a perspective of what that really means, we have just around 15,000 skilled nursing facilities across the United States of America. $75 million would equate to about a $5,000 equivalency for each of these nursing centers when you break it down. The reality is that the centers today are spending well over $5,000 of their own money each and every year on these recruitment efforts and finding unique ways to be able to retain their workforce, bring additional individuals in, but there's barriers that are put in place. There is no pipeline. To create an RN, that's 4 years of dedication from that person. There are no overnight changes that can happen to the program itself when the individuals just do not exist. And being a national mandate, it's not like you can pull upon other states and surrounding. They're in the same boat. Additionally, CMS has programs in place that allow us to be able to do CNA training programs and grow our own. These are fantastic programs, and many of our providers take advantage of these. The issue is that CMS also has a 2-year training ban for centers that that have a particular issue within the home. Many times these are these issues have been resolved and were left from past administrations in those facilities, and that the new individuals are the ones that are bearing the brunt of that. When you look at this from the state of Kentucky, many of our counties only have one nursing home within them. If you take away the one center that can produce CNAs within that area, you're now forcing them to look for individuals to not only pay for the individual to go through the training program, but pay for the cost of the transportation, which is oftentimes a barrier in these particular areas. And oftentimes it's having to partner with other providers to be able to provide these services. Okay. So what happens here? It really ultimately comes down to the end result of access for seniors in care is in jeopardy. The facilities, and many have already looked at doing this over time, have had to reduce admissions. They've downsized, and we've seen closures across the country and here in Kentucky. The care access is going to worsen, and it'll be exacerbated in the rural areas. 3,600 nursing home residents are estimated to be displaced by this and the actions that come from that. And we're also going to see our nursing homes facing increasing pressure because as our capacity it shrinks and decreases, they are going to be the ones who will have to be left afoot to be able to care for these individuals.
Folks, you're doing a great job in this presentation. You truly are. But we've got about 4 minutes before we have to move on to the next agenda item.
Thank you. So we've had several closures in the state of Kentucky, to give you a list right here beyond. Within those, I'll also realize that 20% of the nursing homes across the country have either a closed unit, wing, or a floor due to labor shortages already. When it looks at workforce and retention, what are Kentucky's nursing homes doing, planning, and putting out there? They've already started to work on retention programs. They started these several years ago. Bonuses have been put in place, wage increases have been put out there, career development opportunities. All of these things are happening currently right now, but we're ultimately competing against each other because it's the same pool that are available. When we look at this, we would like to first off say thank you to you all, because with House Bill 200, it's creating workforce funding, scholarships, training programs to help. And these will help over time, but they take time to be implemented, and it takes time to put people through these programs. We are also extremely grateful for the rebasing on the Medicaid that had not happened in quite some time. Your all's efforts in putting that forward have really saved some closures of nursing homes across this state currently, and will help in this effort and allow for more competitive wages. But the increased wages does not change the supply-demand issue that we are facing. When it comes to policy, Lisa had spoke on the ACA lawsuit, and we're working through that to see what actions we can take in that regard. And from technology, we are really trying to push and work toward telehealth to be able to help to meet those 24/7 requirements for those RNs, particularly in those rural-based communities where we know they are not going to be available. And we're also looking at different technologies, AI-based, that can help to make them, make the physicians, or not the physicians, the nurses in that more capable in what they're doing to recognize areas to be able to go and focus in on beyond that. So with the exemptions themselves, they are planning for applying for these in the rural-based communities. The trick is you don't know if you get it until they walk in the door. So technically you are out of compliance. And if you do not meet the exemption for that, you will continue to be out of compliance with additional fines, which exacerbates the same issue. So in wrap up, I believe that we all in this room and in our industry desire to provide the absolute highest quality care for our most vulnerable residents of the state of Kentucky. This mandate exceeds our capacity for workforce capacity within the state itself. And ultimately, these ramifications from this mandate are going to could lead to additional closures and ultimately higher costs for our state. Because as these are being implemented, Medicaid being the primary funding source for many of these residents in nursing homes, with the processes will be pushed back to a rebasing, and we will see higher wages. We will see higher allocation of those labor resources, which means that the state is going to ultimately fund a large portion of this versus the federal government. So as we find our path forward, knowing what we support having the RNs readily available. We support telehealth as a stopgap for us in a way to help rural areas and smaller nursing homes. The situation will not improve in any way meaningfully in several years. We need the policies, the resources, and the flexibilities to recognize and address these issues. And we need to really incentivize our nurses and the people that are out there looking at careers right now to look at the long-term care industry as a viable option for them and a true career path to move forward in the future.
I want to tell you again, excellent presentation, and I can't say I'm surprised by any of the slides. I kind of see what was on the horizon. I was blessed to start my healthcare career in the long-term care industry, and one of the greatest blessings of my life. It takes special people to work in long-term care, and they truly angels walking on the face of the earth. You do have a crisis of biblical proportion, and I think it's interesting all the presentations we've heard today. He talks about how it impacts rural communities, and it is dire. We have time for one question, then we need to move on. Senator Berg.
Thank you, Mr. Chairman, and thank you for your presentation. I do want to make an observation, and then I do have a question. I recently had a sister who was put into a nursing home in Louisville. And I will be honest, the experience was abysmal. Abysmal. I mean, to the point where we just simply removed her. First day I go in, I asked to sign a HIPAA release because I am a physician and my sister is being in this facility. They don't know how to provide a HIPAA release for me. They have no way of doing that on site. Zero nursing care. Zero. 4+ pitting edema never addressed. nobody even looked at her. So I'm going to tell you, at least at this specific facility, I do not think you all are doing your jobs, because the care was beyond horrible.
Senator, we need to
Okay.
move on. I appreciate the
Does
situation. But we need to move on.
telehealth cover the obligation for 24/7 on-site nursing? Can you cover that obligation with telehealth?
No, not at this time. That it is not allowed for with this mandate, if that's what you're asking.
Okay, thank you.
Yeah.
You know, you folks are certainly a victim of everybody wants the best health care somebody else's money can buy. And I appreciate that numerous people have had the same type of experiences that Senator Berg's family has had. I don't cast dispersion on you folks because of that. You're a victim of the system that's been woefully underfunded for years. You talk about rebasing. We hadn't done that for 20 years. How can you provide quality care in that kind of setting if we don't provide the reimbursement? So we're as much as fault as anyone with this current situation, and it's inexcusable. But I appreciate you being here today. Please know that you can reach out to us anytime to work on plausible solutions to address this issue, because it is a crisis. But thank you for being here. Our last presentation day, and a very important one for us, is called Heroes to Healers. I'd ask our presenters to come forward. She says no. You know, my agenda identifies most of you. It also says Dr. Ryan Quarles. I don't think any of you are Dr. Ryan Quarles. So if you would, please identify for yourself for the record and proceed.
Aaron Thompson, Council on Post-Secondary Education.
Representative Steve Bratcher, 25th District.
Dr. Phil Neal, I'm the Executive Vice President and Provost for KCTCS. I'm here in place of Dr. Ryan Quarles, who sends his regrets.
Kelly Jenkins, Kentucky Board of Nursing.
Glad to see y'all be here this morning. This certainly is a collaborative relationship here, and I'm very encouraged by that. And just for committee members' information, I think this group's also going to present to VMAP, which starts at 11 o'clock, so we'll hear it again. But we thought it was important to get this out. One of our goals is to be one of the most veteran-friendly states in the United States, and I think this falls within that parameter in scope. But also to try to address the workforce shortage that we've talked about throughout this meeting. So please proceed.
Thank you. Basically, this bill was brought forward by some of the people sitting at this table and behind the table. But I'm sponsoring this bill, and I appreciate Chairwoman Mosier primary co-sponsoring this bill too. But basically what this does is it takes a military medic and converts them over to an LPN and which eventually can bridge to an RN. And we think it was important to get people, all the parties involved that would have a hands in this, which would be obviously the Board of Nursing as well as the CPE, and then we have KCTCS, which can create or build that bridge academic. If there's depending on which branch they come from, can build that bridge over academically to the RN or to the OPN. So with that, I'll be happy for you all to.
Let me start off by saying that, as you all know, we do have a health care shortage. You know that. And for many years, CPE, we've been establishing processes to actually try to combat that. We also know that to keep our economy going, we're going to have a lot more people in our workforce that's educated to do that. So that's been our primary goal, at least since I took over higher ed. Several things I want to point out here. When we start traveling around the state talking to people, and we've talked to over now 4,000 or 5,000, tomorrow I'll be back on the tour again, and we had a chance to go visit Fort Campbell and talk to those at Fort Campbell, and realizing that Kentucky, we were not doing nearly as much as we could to help many of these veterans who are coming out with leadership abilities, all kinds of training, to really move quickly into the workforce. So Dr. Sizemore, I have to give her a lot of credit because she does a lot of the hard work. I mean, in these conversations that we started having, we started coming up with what we call bright ideas, and this was one of them, the Heroes to Healers. And so it's about adult learners, true enough, but it is also about getting these highly trained veterans in our workforce that will stay in Kentucky and stay in our workforce. Now, I can give you all the background, I can tell you all the conversations, but I will say, at least from CPE's vantage point, this is just the start of actually working with many of these former military folks to actually create many more jobs way beyond healthcare. But this, in fact, is what this is. It's taking these veterans with all kinds of backgrounds, giving them really good credit for prior learning, creating bridge programming, and getting them in this workforce at a fairly rapid rate.
Thank you, Chairman and Committee, for allowing us to share just a few thoughts here. For KCTCS, we have had a strong track record over the years of LPN, RN, as well as a variety of other training programs to meet our industry needs, and we are certainly proud and dedicated to helping as many of our veterans enter civilian life and reach that career goal as quickly and as flexibly as possible. We have a commitment to working on this partnership with the Kentucky Board of Nursing and CPE and certainly our military to create pathways that will diligently put forward these veterans as well as working with them in active military life. We have already created in the past a medic to RN program, and we do a lot of credit for prior learning in a number of healthcare arenas such as dental hygiene and several areas such as aviation maintenance, diesel mechanic, and other vocational areas. So our commitment is to work in collaboration with all of our partners to help create a bridge after analyzing the new curriculum that's coming from the military, as well as ensuring the highest quality education that we possibly can to ensure public safety and meeting our healthcare partners' needs.
And I just want to reemphasize, I appreciate post-secondary education allowing the Board of Nursing to be at the table. We also have worked with KCTCS in the past with the bridge program from medic to RN, so we're more than happy for our education consultants at the board, who I consider my expertise in that area, to work on this bridge program to LPN. And our goal is to protect the public, but we also know that we need to be consultative and work with various agencies and in trying to improve this workforce shortage in Kentucky.
So in this particular situation, we're focused on medics to RNs. And so you have three different branches that have medics with the Air Force, the Navy, and then the Navy have corpsmen, and the Army has medics as well. They all kind of get similar, same training in the beginning. But towards the end, the Air Force branches off and goes to clinical settings, which is hospitals and clinics. And because of that, they get a little more additional training in the clinical setting. They already have a pathway to where they can become an LPN. So once the Air Force finishes their testing or finishes their training, they can go and take the exam for the LPN licensure. Unfortunately, the exam pass rate isn't really that high, so we may need to look at some sort of bridge cram course or review session or capstone to try to help that improve. The military Army medics and the corpsmen go to the field, so they do battlefield medicine more or less. So their training, and compared to the Air Force training, is a little bit different. So there may need to be a little bit more of a bridge in that area, and that's where KCTCS comes in with 16 community colleges. Statewide, they can help identify, along with the Board of Nursing, what those gaps are. Well, for example, they may not have had some clinical settings in the ER or clinical settings in certain other areas. So KCTCS can help bridge that gap to make sure it meets the requirements of nursing through the Kentucky Board of Nursing. We're not trying to lower the standards at all. We're just trying to make a pathway to where people can come from the military and have that background in the military and move on to a viable field. And then further on, once you get an LPN license, you can move on and do a bridge to get an RN. So essentially trying to fill that gap. To keep in mind, the military today, 40% of your military right now is in the Guard and Reserve, 40%. And so that equates to just under 800,000 people in the Guard and Reserves. So 800,000 people in the Guard and Reserves nationwide is an opportunity for employment for people that are actively serving. That does not include retirees or people that are getting out on a daily basis that have this skill set. So I think this is a huge opportunity that we may not have been focused on in the past for workforce development and trying to help the economy. So with that, I'll if you don't have anything else, I guess we'll take any.
I have one more item. This isn't medic to LPN. but as someone who's been in healthcare for a long time myself in the governor's portion, these hospitals and other healthcare agencies will actually supply dollars, and too many of these that become LPNs to move to RN. So this is a pathway process, and let me say something about quality. Yes, we will make sure that they bridge themselves to the clinical quality, but you also have to understand many of these military veterans are people with problem-solving ability that we sometimes don't produce in post-secondary education. So some of these items that we're talking about is really allowing some of these other competencies to triangulate with this clinical quality. So our goal is to truly become the most military-friendly state in the nation when it comes to post-secondary and getting people in the pipeline.
I would like to add a couple more items too. The military medics are trained far beyond the level of sometimes an EMT, and they can do things in the military that they couldn't do in the civilian world. So some of their training is beyond the level of what a EMT would be or an LPN right now would be in some areas. In some areas they may be lacking. But also wanted to bring your attention, there's a program called Skill Bridge. And the Skill Bridge program that the Army has right now, it's 6 months. When you get 6 months to the end of your tour or the end of your duty, you can go through the Skill Bridge program, which the Army will continue to pay you for 6 months to learn a skill to go into the regular workforce. Because we also recognize that homelessness among veterans is high as well.
Thank you. I have a couple of questions. Representative Dotson.
Thank you, Mr. Chairman. This kind of hits a little home for me because I was a medic in the military as well. I went to X-ray school in the military, and I was able to transition rather smoothly from the military into the private sector. I started working at UK Hospital, but I had to take the ARRT, the test there. So with that being said, would there be a testing model that may be put in place? Because as Representative Bratcher said, there is extensive training in the military. I passed that exam with rather ease, and I was just wondering, rather than having to go back and do a lot of extra training and go back to school, if there's a testing in place that they may even be more qualified than maybe some that are coming right out of school. So I was just wondering if there's an exception for that.
So the National Council of State Boards of Nursing sets our testing standard, which is the NCLEX. So what Kelly and her team will do at KCTCS is just identify those gaps that they did not get didactic curriculum training. And so it's going to be like maternal health. It might be psych mental health. It's going to be pediatrics. It's going to be things that maybe they didn't get didactic coursework, and they can do those classes in 7-week classes. So it'll be an accelerated program.
Thank you.
Go ahead. Did you have another question? Just to reiterate, if you think about the military population, you're dealing with people from 18 years old to maybe 45 or maybe a little older like myself that are in the military still, but you're dealing with a primarily healthy individual. And so, but some of the medics also see family members. So you have families that accompany these soldiers and airmen on bases, and so they see family members as well, and they also see kids. But as to what Ms. Jenkins said was that, yeah, they may not get the maternal piece, or they may not get the newborns, and they may not get some of the other stuff, but they probably would get the emergency medicine quite well. And Representative Dodson, it would give me no more comfort to know that if I ever went into surgery or something and you were there as a transition as a nurse, I'd feel comfortable. So thanks.
I would also like to add that we do have a robust credit for prior learning. So there's other items they could get credit for that would actually not only help them in this case, but also as they move forward if they want to go toward an RN.
Thank you. The last question, comment from Co-Chair Moser.
Thank you, Mr. Chairman. I don't really have a question. I have just a comment. I'm really pleased to help with this proposal. Thank you to CPE, Dr. Sizemore, for bringing this, and all of you for collaborating on this great initiative. I just think it's, obviously it's twofold. It helps address our healthcare workforce shortage, and it is mission driven in that it really helps our active duty military transition to civilian life and into the workforce. So I'm very proud to keep working on this, and thanks for all of your work.
Just one more comment, if I don't mind, is that I appreciate all the members of the different organizations working together to show how we can work together to do better for the Commonwealth.
Thank you. Appreciate the presentation. Great subject matter. I appreciate the attention and cooperation of all the committee members today. A very full agenda, but we got through it. Just a reminder that our next meeting is Wednesday, October 23rd at 9 o'clock a.m. So please put that on your calendar. Thanks everyone for participating today.